Hello everyone, so we are starting GIT module and we're beginning with physiology, and the first topic in GIT physiology will be swallowing. Now swallowing is something that happens after the mastication of the food and the formation of the bolus. So some things that are good for MCQ purposes is that the muscles of mastication are innervated by the fifth cranial nerve, and only masticated food can be properly swallowed. Swallowing is made into a complicated process mainly because the pharynx, which is involved in swallowing, obviously, is involved in both respiration and swallowing. And during swallowing, you do not want to compromise your respiration, which makes swallowing a complicated process. Now, swallowing has two stages. We have a voluntary stage which is under conscious control, and then we have an involuntary stage that is no longer under conscious control, something that can come up in an MCQ. The involuntary stage is divided into number 1, the pharyngeal stage, and number 2, the esophageal stage. As you can see, voluntary stage over here. These are the two subdivisions of the involuntary stage, right? I'm hoping that this chart that I've made is useful for you. Now, so the bolus of chewed food, which is basically a ball of chewed food which has been lubricated by the saliva, right? In the voluntary stage, this bolus is forced by the tongue, right, into the rear of the mouth and then into the pharynx, right? So the rear of the mouth is basically what the posterior part of the mouth. And how does the tongue propel the bolus of food in the mouth cavity into the rear of the mouth and then into the pharynx? It basically applies pressure on the bolus of food against the soft palate. The pressure is applied upward and backwards, and that is how the bolus of food is propelled. You can do it yourself. You know the soft palate, the palate of the mouth cavity, which is basically the roof of the mouth cavity, and obviously you know what the tongue is. So how that happens is that, imagine this on yourself. The tongue presses the bolus of food against the soft palate, right, and it applies the pressure upward and backward on the bolus of food against the soft palate, and because of this, the bolus of food is propelled into the posterior of the mouth and then into the pharynx. This is voluntary. This is something you are doing and you can stop doing while you're doing it. So I happen to have letters with me and I'll show you a couple of things. Right, this is the muscles of the pharynx shown, but let's go to the, again, this is the various views of the pharynx. So right, this is the mouth cavity, this is the tongue, this is the soft palate, this is the rear of the mouth. So the tongue, basically, this is the tongue. It propels the bolus of food into the rear of the mouth and then into the pharynx. What is the pharynx? All of this is the pharynx, right? And this is the opening of the mouth into the pharynx, right? So I'm hoping that these visuals are helpful to you. Now I'll come back to the flow chart. So after this has been done, after the food has been propelled by the tongue into the rear of the mouth and then into the pharynx, right? So the bolus of food in the rear of the mouth and the pharynx, it stimulates. What does it stimulate? Epithelial swallowing receptor areas that are all around the opening of the pharynx, and especially they are present on the tonsillar pillars. So that bolus of food, it basically strikes against those receptor areas, those epithelial swallowing receptor areas that are found around the pharyngeal opening and are most abundant on the tonsillar pillars. Again, I'll be showing you a diagrammatic representation of this. Right, this is not that good of a view. So this is basically when we have cut the pharynx posteriorly, so you can see anteriorly. So this part is the oropharynx that we are concerned with, and anteriorly we can see the root of the tongue, so we have the mouth cavity anterior. So this is the opening of the pharynx, and the opening of the pharynx basically has a lot of abundant epithelial swallowing receptor areas, especially the tonsillar pillars. You can see the palatine tonsil over here, and when the bolus is propelled backwards into the rear of the mouth and into the pharynx, it presses against these epithelial swallowing receptor areas abundant around the pharyngeal opening and especially on the tonsillar pillars, and this basically initiates the involuntary part of it, the involuntary part of swallowing. So when this has been done, the next sequence of events that will eventually complete swallowing is no longer under conscious control. You cannot stop it after the next stages have begun. Right, back to the flow chart. So I'll go over this again. So the bolus of food in the rear of the mouth and the pharynx stimulate the epithelial swallowing receptor areas all around the opening of the pharynx and especially on the tonsillar pillars. And what happens then is that impulses, they pass to the brainstem and they stimulate a series of automatic pharyngeal contractions. So what exactly happens is that afferent impulses are sent via the sensory fibers of two cranial nerves, cranial nerve 5 and cranial nerve 9. So the trigeminal and the glossopharyngeal. You can see this path, right? And the impulses are sent to the sensory nucleus in the brainstem known as the nucleus tractus solitarius. From there, the impulses are sent to the swallowing center found in the brainstem, and the swallowing center is basically constituted by neuronal areas of the reticular activating system of the medulla and the pons. So we have the afferent impulses of the 5th and the 9th cranial nerve going to the NTS, and from there to the swallowing center. So these are the afferents. Now the efferents are going to be sent via 4 cranial nerves, the 5th, the 9th, the 10th and the 12th, right? And eventually what they're going to do is that they're going to be sent to the pharynx and to the upper esophagus, because swallowing will involve the pharynx and the esophagus, because we have involuntary pharyngeal stage and we also have the involuntary esophageal stage. So I'm hoping I'm really explaining this well, because this is a bit of a complicated thing to understand, right? So this is the reflex part of it, and the reflex part of how the involuntary stage is initiated. The bolus of food that is propelled by the tongue into the rear of the mouth and into the pharynx via the pharyngeal opening, it presses against epithelial swallowing receptor areas all around the pharyngeal opening and especially on the tonsillar pillars. And what this does is that sensory impulses are generated and subsequently transmitted via the sensory fibers of cranial nerve 5 and cranial nerve 9 to the nucleus tractus solitarius in the brainstem, which is a sensory nucleus, and from there to the swallowing center. And from the swallowing center, efferents are sent via the 5th, the 9th, the 10th and the 12th cranial nerve to the pharynx and the esophagus, because we have the involuntary pharyngeal and the involuntary esophageal stage. So after that, we will have a set of changes taking place in the pharynx and the esophagus, which are involuntary and automatic and sequential, which will lead to the completion of the swallowing process. You can understand this is pretty intricate. Now in certain conditions, for example in in oropharyngeal dysphagias, right? This reflex is going to initiate the involuntary stage, right? But in oro, meaning oral cavity, pharyngeal meaning pharynx, in oropharyngeal dysphagias, right? I'll basically show you first, let me define dysphagia. Deglutition and swallowing are the same thing. They're referring to the process of swallowing, whereby a bolus of food is transmitted from the oral cavity to the stomach. Dysphagia is a condition in which a person has difficulty swallowing or is unable to swallow, and you tend to divide it into oropharyngeal dysphagias and esophageal dysphagias. In oropharyngeal dysphagias, the process whereby which swallowing is initiated, there is a problem over there somewhere. I want you to just keep these in mind, because we will also consider the clinicals, because they are rather important as far as MBBS part 2 is concerned, first year part 2. Now let's talk about the sets of changes that make up the involuntary pharyngeal stage that allow the swallowing to take place. So talking about the sets of changes that take place, now this is a bit messy. I was hoping it would not be, but if you listen to my guidance, it will be really helpful. So what are the sets of changes? We have 1, 2, 3, 4, 5, 6, 7, 8 changes, right? And of these, which are we concerned with? All of these, because they're part of the involuntary pharyngeal stage. First of all, if you take a look at this image, you know, this is the pharynx, and you know that we have in the nasopharynx, which is continuous with the oropharynx below, we have the posterior nares, which communicates with the nasal cavity, and in the laryngopharynx we have the laryngeal inlet. We have a communication with the laryngeal inlet. So keeping this anatomy in mind, I would like you to listen to me. Again, let's go back to the flow chart. My apologies. Right. So the soft palate is pulled upwards to close the posterior nares. And what is the purpose of this? We don't want any of the food to reflux into the nasal cavity. That is why the soft palate is pulled upwards and the posterior nares are closed. In this image, we can see the posterior nares, right? And in the images before, you can see this is the soft palate, right? You can see this is going over here. My apologies, this is the soft palate, right? And the soft palate is pulled upwards, and when the soft palate is pulled upwards, this is the posterior nares, and this is the nasopharynx, and the posterior nares is the communication between the nasopharynx and the nasal cavity. So during swallowing process, during the involuntary pharyngeal stage, as a consequence of the efferent impulses coming back via the 5th, the 9th, the 10th, and the 12th cranial nerves, one of the first changes that are going to make this happen is the fact that the soft palate will be pulled upwards to close the posterior nares, because you don't want any of the food to reflux into the nasal cavity. We want it to reach the stomach and don't want it to enter the nasal cavity. So this is one of the first changes that will take place. Sometimes anatomy is really important for you to be able, actually most of the time, but sometimes it is really important. It's rather hard to understand without these images, right? I'm hoping you're with me still. So this is the first change. The second change is over here. We have the palatopharyngeal folds on each side of the pharynx, and they're pulled medially to approximate each other. So if you look at an image of the pharyngeal opening, on either side you will have these palatopharyngeal folds because of the palatopharyngeal muscle. So as part of this, they will be approximated, and they will be approximated medially, and because of that, the pharyngeal opening will be reduced to a slit in the midline known as a sagittal slit. This had a preventive mechanism to prevent reflux into the nasal cavity. What is the purpose of this sagittal slit? It is a selective mechanism, because we only want the masticated bolus of food entering into the pharynx. We don't want any large particles getting into the pharynx, and this step basically lasts for less than a second. And the purpose of this is to exclude any large unmasticated product that you should not be swallowing in the first place, right? So what is the third? Now the third thing that you want is that you don't want the food to reflux into the respiratory system, right? And we know that the laryngopharynx communicates anteriorly with the respiratory system via the laryngeal inlet. Right, this is the laryngeal inlet over here. This is the laryngeal inlet. It is even better seen in this image where the pharynx is cut open posteriorly. You can see this is the laryngeal inlet and this is the epiglottis, right? So what happens is that we have three changes happening. First of all, the larynx is pulled upwards and anteriorly, and this is accomplished by the muscles of the neck. So the muscles of the neck muscles do have an important role in the swallowing process, right? So this is pulled upwards and it is pulled anteriorly. It is better seen in these images. So this is the larynx, because you can see the thyroid cartilage. You can apologies, this is the epiglottis. You can see this is the thyroid cartilage and this is the cricoid cartilage, etc. This is the lamina of the cricoid cartilage. These are the arytenoid cartilages, and again this is the cricoid cartilage. So this is the area of the larynx. So what happens is that this larynx is pulled upwards and it is also pulled anteriorly. This over here is the, what is this? This is the sixth. After this we have the esophagus. After the sixth we have the esophagus, right? This over here is the, what is this? This is the laryngeal inlet, and this over here is the area of the laryngopharynx. After that we have the esophagus. So when the larynx is pulled both anteriorly, both anteriorly and upwards, this is the first step that takes place. What is the reason for this? It will have multiple effects. There are multiple reasons for this. Other than this, the vocal cords of the larynx are strongly approximated. These are the vocal, you can see one of the, right? Because this is a sagittal section, so we have two of these on either side, and these are approximated medially, and the purpose is that should any food get in over here, it is not able to proceed further because the vocal cords have been approximated medially. Second step, that is preventing aspiration into the respiratory system, because that is really bad. Now third thing is that the ligaments, they prevent the upward movement of the epiglottis with the larynx, and because the epiglottis is fixed by the ligaments, it will swing backwards over the laryngeal opening and will therefore close it, right? The larynx is being pulled upwards and anteriorly, but because of the ligaments, because of the attachment to the hide bone, for example, it is not able to move upwards with the larynx, and so when this will move upward, it will swing backwards over, this is the laryngeal inlet, swing backwards over the laryngeal inlet, effectively closing it. So these three steps are going to prevent reflux into the respiratory system. Secondarily, because of the movement of the larynx, the inlet is now no longer in the way of the food, whether it is being pulled upwards and anteriorly, so the food will not go over the epiglottis, rather it will go over its sides and enter into the esophagus. Another set of changes that must be kept in mind. Because of this, the opening of the esophagus is enlarged. How is that achieved? Again, I'll show you the image. This is the opening of the esophagus. Because it is being pulled upwards and it is being pulled anteriorly, this opening will be enlarged, and this will make the involuntary stage of esophageal swallowing much more easier. Because of the movement of the larynx, the esophageal opening is enlarged, right? And as the food will approach the esophagus, there will be relaxation of the upper esophageal sphincter. Normally, when you're not swallowing, when a person is not swallowing, is not eating, it is constricted. It is tonically constricted, and the intraluminal pressure is about 30 millimeters of mercury. We're talking about the upper esophageal sphincter and not the lower esophageal sphincter right now. So in between swallows, it is tonically constricted. It is only opened when a person is swallowing and the swallowing process has been initiated because of the reflex that was initiated by the bolus pressing against the epithelial swallowing receptor areas. Now, ignore this for now because this is more for the lower esophageal sphincter, right? And also, after the initial changes, after the soft palate has been pulled upwards and the larynx has been pulled upwards as well and the upper esophageal opening has been widened, the pharynx musculature begins to contract from above downwards, and this pushes the bolus into the esophagus. So these are the sets of changes that must never be forgotten. The pharynx is a muscular tube, so obviously there will be the involvement of the muscles. We have the circular and we have the longitudinal muscle. So obviously they will also have a part in contracting and propelling the food into the esophagus. Right, so these are important things to understand. Again, the 30 is something that is more for the lower esophageal sphincter, not for the upper. But you must remember that the upper esophageal sphincter is always tonically constricted as well. Now, if a person has oropharyngeal dysphagia, oro for oral cavity, pharyngeal for pharynx, meaning swallowing difficulty, that with the pathophysiology originating somewhere in the initial stages of swallowing. So the person is basically sometimes unable to even initiate the swallowing process. Secondarily, such a person will suffer from repeated nasal regurgitation because this step will not be happening as it should be happening. There might also be aspiration of food into the respiratory system and resulting in aspiration pneumonia, which is a kind of pneumonia obviously. Right, so these are the causes of oropharyngeal dysphagia. Right, now what can be the causes of oropharyngeal dysphagia? There can be neuromuscular disorders, something to do with the nervous system and the muscles, like in polio, right? In diphtheria infections. So polio is a neuromuscular disorder that involves the lower motor neurons, and diphtheria is something that you probably at least heard of. And these can be the causes of oropharyngeal dysphagia, which is the first type of dysphagia. Dysphagia, swallowing difficulties, is divided into two criteria for ease of learning. Oropharyngeal dysphagia, in which the pathophysiology is originating in the initial stages, and esophageal dysphagia, where the pathophysiology is originating in the esophagus. So it can be local throat problems, and throat is a colloquial word for the pharynx. For example, we can have tonsillitis, which is inflammation of the tonsils in which they become swollen, and so they can obstruct the bolus of food. For example, we have them in this image. It will be clearer to see. We have the tonsils, the palatine tonsils over here. So in tonsillitis can lead or can be a local problem for the development of oropharyngeal dysphagia. There might be a local inflammatory process. There might be pharyngitis, which is inflammation of the pharynx. Whenever there's itis, it means inflammation, right? Now there's something known as Plummer-Vinson syndrome, which develops in some people. It is rather common who have developed iron deficiency anemia. And in such people with Plummer-Vinson syndrome, for whatever reason, the pathophysiology is not 100% clear cut, they develop oropharyngeal dysphagia. Plummer-Vinson syndrome. So this has to do with the pharynx, right? And also there might be a neoplasm in the area of the pharynx, which can be directly obstructing swallowing, or if a person is in deep anesthesia, because there's the involvement of the involuntary pharyngeal stage, which needs the epithelial swallowing receptor areas to be stimulating, efferents being conducted via the 5th and the 9th cranial nerves to the NTS and then to the swallowing center, and from there via the 5th, the 9th, the 10th and the 12th to the pharynx and to the esophagus. So for the involuntary pharyngeal stage to happen the way it should be happening, there needs to be activity of the nervous system, but in deep anesthesia all of this is inhibited. So a person who is in deep anesthesia will be suffering from oropharyngeal dysphagia during the course of the deep anesthesia. Now, so we've kind of done the causes. Now let's talk about the symptoms again. Inability to initiate swallowing in a person with deep anesthesia. Repeated nasal regurgitation and aspiration pneumonia. Right? Because obviously if all of this is not happening the way it should be happening, the soft palate will not properly close the nasal cavity and the laryngeal inlet will not be properly closed off. So we can have these symptoms developing in a person with oropharyngeal dysphagia. Another common cause which I forgot is in rabies, because a person suffering from rabies has the development of muscle spasm, and it can be said that a person has water fear, even though that fear is a conditioned fear, because whenever a person who has developed rabies tries to drink water, there is painful spasmodic contraction. Because of the pain, that person develops a fear for whenever they see the water, when they're still suffering from rabies. So I'm hoping I kind of clarified the causes. We've talked about the voluntary stage, which initiates swallowing or leads to the initiation of swallowing, involuntary, and the first involuntary pharyngeal stage. We've talked about it, and we've talked that if the dysphagia, swallowing difficulty originates at these two stages, the symptoms will include nasal regurgitation and aspiration of food into the respiratory system, because part of the involuntary pharyngeal state is to prevent that from happening. So obviously when it is not working the way it should be happening, that will not happen. Either that or the swallowing will not be initiated in the first place. I will go over the possible causes again. Some stuff that can be asked in a viva. Rabies, because there can be a particular scenario based around it. Also around Plummer-Vinson syndrome. Something you need to understand is that you just don't need to know that there's a development of dysphagia in rabies and in Plummer-Vinson syndrome. You need to be able to tell that it is an oropharyngeal dysphagia. In the case of tonsillitis and pharyngitis, remembering that is much easier because you probably know the location of the tonsils. Neoplasm is something that can be for the esophagus and for the pharynx. Deep anesthesia is again is specific to the oropharyngeal, because it is before the pharyngeal stage is initiated that we have the initiation happening, right? Because it is before that we have initiation of the reflex. Right, so now let's talk about the esophageal stage, which is comparatively much easier. Right, I'm hoping you'll be with me again. Right. So this is the esophageal stage, involuntary again for MCQ purposes. Now there are two kinds of peristalsis, primary and secondary. In the case of primary peristalsis, it is simply a continuation of the peristalsis that developed in the pharynx during the involuntary pharyngeal stage, and that continues down the esophagus, and the food is propelled into the stomach. And this stage takes 8 to 10 seconds normally, but when a person is standing and gravity is in the favor of said person, the food will reach 5 to 8 seconds to reach the stomach, even though the peristaltic wave will still obviously take 8 to 10 seconds. So the food will reach before the peristaltic wave. Now that is easy enough. And when the food reaches the lower esophageal sphincter, right, what happens is that the lower esophageal sphincter is always tonically constricted in between swallows. The intraluminal pressure is important. MCQ wise it is 30, but as the peristaltic wave approaches the lower esophageal sphincter, in anticipation of it, before it is actually reached, there is relaxation of the sphincter and the intraluminal pressure drops from 30 to 0. and this allows the food to enter into the stomach. Normally, when you're not swallowing, in between swallows, it will always be closed. Very important, this prevents air from entering into the GIT tract. GIT is for tract anyways. Right, now this is a lower esophageal sphincter, very important. It should be working this way. Tonically constricted in between swallows and at zero when a person is swallowing and the peristaltic wave is about to approach. Now there's also another thing, sometimes secondary primary peristalsis is insufficient and some of the food accumulates. Now does it stay over there? No. Normally if the person is quite healthy, what happens is that the distension caused by the food that was retained causes another peristaltic wave to develop at the site of the distension and move downwards. Now there are two possible mechanisms, both probably work together. Intrinsic neural circuit involving just the myenteric plexus of the esophagus itself, and sometimes involving vagal afferents. Right? Both of them probably work together. Vagal afferents, what they do is basically the impulses, they are sent to the medulla, and in the medulla we probably have the center of this reflex. And efferents are sent not only in the vagus but also in the glossopharyngeal. So it's not just a vasovagal reflex, because the ninth cranial nerve is also bringing the signals. But in a person, and this is rather important, because in a person whose swallowing reflex is not working because of brainstem swallowing center paralysis, that person can still be fed with a nasogastric tube. Right, because a nasogastric tube, it basically operates by secondary peristalsis. Food is dropped into the esophagus directly, causes distension, leads to the production of a secondary peristaltic wave. But even if this reflex is not taking place because the vagal nerve was also cut as part of the trauma, in a couple of days the secondary peristalsis will be operational again, because the myenteric plexus in the esophagus will in compensation will become more excitable. So this was for the esophageal. Now normally the LES, the lower esophageal sphincter, is supposed to open in certain and be tonically constricted the rest of the time, but sometimes disorders originate at this level. But before that, let's talk about esophageal dysphagia and the possible causes. Right, so there is a concept of ecclesia, and that is something to do with esophageal dysphagia. Ecclesia is when the lower esophageal sphincter is not always tonically constricted the way it should be at an intraluminal pressure of 30 in between swallows. Right? It is like that. My apologies. It is like that. But also when it is supposed to open in anticipation of a peristaltic wave, it remains tonically constricted. Such a condition is known as ecclesia cardia, when it is not opening when it should be opening. And in a person suffering from ecclesia cardia, not only is it a disease in its own right, but it is also the most common cause of esophageal dysphagia, because when it is not opening, obviously swallowing will be hindered at the level of the esophagus. This is a very important MCQ. They can ask you for the most important cause of esophageal dysphagia, and the answer might seem very hard to you, but it is not. So the commonest cause is again ecclesia cardia, which means narrowing of the esophagus at the lower esophageal sphincter. There can also be strictures, in which there are strictures in the esophagus, and that is usually people who try to commit suicide via taking acid, and they could be saved. But because of the damaged strictures, fibrous strictures developed, and for the rest of their life they will have a very difficult life ahead of them, because they will be difficulty swallowing. As part of some surgery, and sometimes even after surgery, strictures develop, and also due to damage to the myenteric plexus, which can be because the myenteric plexus is involved in primary peristalsis and secondary. There can be other motility disturbances as well, and sometimes cancer, which is a more localized problem. Cancer can also lead to oropharyngeal dysphagia. So the causes, most important, ecclesia cardia, strictures due to surgery or due to acid swallow, damage to the myenteric plexus, motility disturbances, and the more local cancer. Now we have an opposite condition in which in between swallows, when the lower esophageal sphincter should be closed, tonically constricted at 30, but because of whatever reason it is not. Why is this such a bad thing? Because the primary purpose of this is to prevent acid reflux, because with the exception of a small area of the esophagus, the esophageal mucosa is not able to protect itself from the acid that can possibly reflux back into the esophagus, and it will damage, and the continuous damage can lead to metaplastic changes which are bad, can lead to the development of malignancy. So when it is open, when it should not be open, there will be acid reflux, and that can be dangerous. What are the causes of GERD? There are a lot of risk factors. For example, obesity. We have obesity, we have smoking, we have drinking alcohol. All of these are risk factors that make the chances of developing GERD all the more likely. It can be because of an autoimmune condition as well. And if someone were to ask you to define GERD, you would define it as a weakening of the lower esophageal muscle or the lower esophageal sphincter. If it is prolonged, it is untreated for a prolonged duration. First of all, there will be development of metaplasia. Metaplasia is basically when there is epithelial changes. Normally the epithelium is stratified squamous non-keratinized, but because of the reflux it can become simple columnar. Again, this is a question that can be asked. And metaplasia is a pre-malignant condition. It can become something known as metaplasia. Is not it is just epithelial changes. It is not necessarily extremely severe, but over time, if it is untreated, it can become Barrett's esophagus. Spellings are BARRETTS, and in which there is a complete change in the mucosa from stratified squamous non-keratinized to simple columnar. And this is a pre-malignant condition which can develop into carcinoma later on. So as you can see, the complications are really scary if you let GERD go untreated. You can develop carcinoma because of GERD. Why? Because the acid reflux can continually damage the cells, and because of that, because there's so much damage and the regeneration has to speed up to keep up with it, that can lead to genetic changes and the development of a carcinoma. Now, what are the symptoms? Because of the reflux, you will have indigestion, you will have pain that is felt as heartburn. What are the changes that can be done? You can quit smoking. Weight loss is suggested. It is suggested that you do not sleep right after having a meal, but rather a couple of hours after it. Don't take any spicy food, don't take any fatty food. And also, symptomatic treatment, you prescribe H2 receptor blockers. H2 receptor blockers are acted upon by histamine, and this histamine via its action in H2 blockers leads to parietal cells secreting more H+. But when H2 blockers are used, acid secretion is reduced. Or you can go a more direct route and you can basically prescribe proton pump inhibitors. There's also a surgical procedure known as a fundoplication, in which the fundus is elevated above the rest of the stomach. Fundoplication is also one of the treatments for gastroesophageal reflux disease. These are all very interesting things to consider. Now let's talk about Ecclesia. Ecclesia is, as I've already mentioned, I've already explained it to you. It is when the food is retained at the lower end of the esophagus because the LES is not opening. And what is the most common complication of Ecclesia? You must never forget, Ecclesia is the commonest cause of esophageal dysphagia, and the commonest complication of Ecclesia cardia is megaesophagus. Because of the retention of food behind it, the esophagus dilates. Causes can be, there can be plenty of autoimmune causes, neurological causes, and there's also a parasitic disease, Chagas disease, which can lead to its development. Again, what would be the symptoms? The food will be regurgitating. Obviously, because the LES is closed, it is going to regurgitate. Regurgitate means to go backward, and obviously this is a common symptom of both GERD and Ecclesia, which is heartburn. There will be chest pain after you've had a meal. You will cough, again because food is not going the route it should be going. It can reflux into the respiratory system, leading to cough. There will obviously be dysphagia because of the Ecclesia. There will be unintentional weight loss because you will not be getting the nutrition that you should be getting. You will have trouble eating, and there will be the development of malnutrition. Malnutrition will include anemia. So how would you diagnose it? For example, first of all, the first thing you do is a physical examination. If you see a person who is anemic and malnutrition, it is one of the causes. And the more specific diagnostics, esophageal manometry. A manometer is something that measures pressure. Normally the pressure is 30 in Ecclesia, the pressure would be above 30. Gastroduodenoscopy, and you basically insert an endoscope to visualize what is going on with the esophagus and lower downward. You insert an endoscope to get a visual. There's also something known as upper GI X-ray and barium swallow. You basically give a person barium, and if that person is Ecclesia, the barium will kind of be retained at the LES, and when you take an X-ray, there will be a characteristic bird's beak appearance formed by the retained barium at the level of the LES. As I mentioned, megaesophagus is the most common complication that must not be forgotten, very MCQ-ish. Right, obviously there will be substernal pain because of the location of the esophagus. In megaesophagus treatment, you have to take antispasmodic drugs because one of the reasons is because it's contracting more than it should be. There's also esophageal myotomy, in which you basically make an incision at the sphincter to relieve the constriction. An insertion of a balloon can be used to open up the sphincter. Right? So I'm hoping this was helpful. If it was, please like, subscribe and leave a comment.